Richard Hilson is our first speaker, and if I can find Richard's biogun here somewhere, bear with me a sec. Where are you, Richard? Right, there he is. Richard specialises in sustainable healthcare, NHS net zero, and environmental management in the healthcare sector. In addition to 5 years in-house experience as head of sustainability at Frimley NHS Foundation Trust, delivering sustainability programmes and the Green Plan. Richard has worked in partnership with a range of public and private sector organisations to deliver sustainability learning, compliance, data, energy efficiency solutions, and has recently joined GemServe Health as principal consultant to support healthcare providers and their supply chains accelerate the transition to sustainable healthcare and net zero. So I'll pass over now to Richard. So best of luck, Richard.
Thanks, Graham. Okay. Right, good afternoon, everybody. And first of all, thank you very much for having me this afternoon. I hope you all enjoyed your lunch and had a good break. A reasonably controversial morning, potentially, from what Graham was talking about, and just shows that what we're working in is certainly not simple. There are complex issues across our particular units and across the global picture in terms of sustainability and how we deliver healthcare in the UK and more broadly. As Graham said, I work for GemServe, joined 6-7 months ago, having been head of sustainability at Frimley Health, so the vast area of my experience has been in a similar role to James Dixon, but he was far ahead of me when I joined Frimley. So what I wanted to cover today is not to go over the same ground as James did and give a big history of Frimley's particular interventions. I'm going to give a little bit of background on Frimley Health and the Green Plan. But I'm going to outline something called the Green Ward competition that we went through, and particularly to hone in on the power of clinicians to change practice in order to become more sustainable, and how you can peel away a kind of onion of a problem to find more and more areas of carbon reduction. And then give a little bit of background to generally what's in a trust's green plan and how we did it at Frimley to try and integrate it with clinical strategy. And then coming into decontamination to this conference, what my take was, and to see how it perhaps has lined up with what's been said this morning and what's going to be dived into this afternoon. So just to give a little bit of background on Frimley, it's not a particularly large trust, but it sits across a number of local authority areas, which makes it reasonably challenging for a lot of the areas of sustainability. I think the interesting part is that Frimley Park Hospital NHS Trust took over Wexham Park Hospital, so there's a culture difference, and that has happened in quite a few trusts as well. So you can find inconsistencies from one area to another several years after a takeover has taken place. There's a military presence within the Frimley Park Hospital site, and it's the base of Frimley is fairly close to, if you know where Farnborough is, so it's from Farnborough up to Slough and then down to just south of Farnham, which is where I'm from, so relatively south compared to some of the other speakers today. So I'm going to start a bit of a story for Frimley. Back in 2017, we produced our Sustainable Development Management Plan, and at that point, like a lot of organisations and trusts, it was based on the Climate Change Agreement at that time, which was to reduce our carbon emissions by 80% by 2050, and it's been updated more recently. Things become more urgent. So then a trajectory was put in place, and carbon emissions were calculated for our direct emissions, patient travel, and staff travel. And it was based on 4 kind of pillars, embedding the low carbon care vision, so how do you actually get things into place that are in the Sustainable Development Plan, and then low carbon and efficient operations, which is what people were thinking at the time, estates-driven efficiencies, delivering sustainable healthcare. There was little definition of what that really meant back then. And then community engagement, how you get all the patients and the rest of your patient communities involved in healthcare. So up until 2019, there was probably still a very strong emphasis on what was estates-driven. As James said earlier, it's difficult to get a sexy picture of a combined heat and power plant, so I didn't try. I put in a small graphic instead. But we'd done things like, you see at Wexham Park Hospital, which Frimley took over in 2018. That was one of the first things we did, was to put in a combined heat and power plant because the site was operating fully on steam and was falling apart, so there's something had to go in for compliance reasons. And so at that point, it was a sustainable option to take. But only a couple of years later, that's becoming less and less of an option because of its reliance on gas and a huge increased volume in the use of gas. But various upgrades were made, and we did quite a few things on the soft facilities management side, like a war pit. Some of you might have in your trust, which is a reuse portal for general bits and bobs, stationery, furniture, etc. We've got electric pool cars that staff started to use to go out and do their business travel. And then on the soft facilities management and supplier side, we worked with Recomed, who are a consultancy, to start to recycle face masks. And also one of our suppliers was delivering us with medical remanufacturing. I'm sure you know the name Stryker and Vanguard. So things were happening. But what else were we doing to deliver sustainable healthcare? And we realised, actually through conversations with the Centre for Sustainable Healthcare that was mentioned in one of the talks earlier, that the clinical influence on sustainability is huge in relation to what estates can do. So there was a need to kind of get out from our little office at the back of estates where the sustainability manager used to sit and go and engage with the clinicians. So that's what we do. That's what we did. We went out and engaged with the matrons, with senior sisters, with the grand round, etc. These were areas that generally we hadn't done before in order to engage them in the Green Ward competition. So what is the Green Ward competition? It's a sustainable quality improvement competition which is based around clinical teams looking for ways to reduce cost, reduce carbon, and improve the patient experience. So it actually works and picks up similar sorts of projects to the one that Sharon outlined earlier, where you find a problem and then you look at how you can improve that particular issue, both from an efficiency point of view and reduce your carbon and your cost. So you start with a recruitment program, trust-wide engagement, and then there's a workshop with the teams where you map your resources. What's the patient journey look like? What are the carbon hotspots within your particular pathway? And it's general, so it's not in one particular area. The clinical teams then run the project, and the one that has the best outcome for patients, reduces cost by the most and carbon, and has scaled the best will won the competition. So we had 6 teams. There were 3 from each acute site. And the endoscopy team, I'm not going to go into the detail, I'm going to profile a different team, but just out of interest, because I know endoscopy's been mentioned quite a bit, their project was looking at the possibility of not using carbon dioxide as a method for some of their gastro processes. They were looking at the possibility of using either other gases or water. So it's a way of just being able to explore some options that haven't been thought of before. And the way that it worked is for these teams is their workshop was looking at a basic how are you using resources within your particular service, and coming back to a couple of points that have been made previously, it emphasised the fact that there was a lot of the footprint which is in our supply chain with all the resources that we're using, which is often relatively new news to people, and particularly at the top of the waste hierarchy, where, as was made earlier in one of the virtual presentations, the prevention of use of resources is ultimately the way of delivering the lowest carbon care, because we're not actually needing to use those resources to do the process in the first place. So the particular project that I'm just going to quickly profile how it worked was the paediatrics team, and it was an inhaler project. So within the team, then they were prescribing a lot of inhalers to the children coming through the service. And what they discovered was that if we implemented and educated the staff and also the patients about how they could recycle their inhaler better, and simple things like knowing when the inhaler had been emptied and at what point it could be recycled, then that first step within the service was going to save 44 tonnes of carbon dioxide, which is already a decent saving for one particular service. But then the next sort of layer of the onion was to look at, well, what are we prescribing? And so the main inhaler that's prescribed, and probably the name that has always been in my mind when it comes to inhalers, has been Ventolin. So Ventolin has a carbon emissions footprint of nearly 3 times that of Salamol. So the team researched and found that out and realised that if they changed their prescription habits, then they'd be reducing the carbon dioxide through the process. But then they realised that actually in their processes, in the majority of cases, they were already prescribing Salamol for various reasons. But what they found out was that if they engaged with the wider integrated care system, with the pharmacists and with the GPs who are working across the system, is that there was much more of an opportunity. So the point I'm making is that the teams were given the ability to go and look outside of their normal sphere of work in order to make a difference. And I think that's a point that we should remember going forward. So what happened is once the pharmacists who are working across the GPs in the primary care sector had put a message out onto their prescription notice, is that 30% of them switched from Ventolin to Salamol. And compared to recycling, once this switch had been made, then the annual saving was 363 tonnes. So the penny starts to drop on when we think of our models of care, that just through a change of prescription, we can reduce the carbon by a multiple of what we would just achieve through recycling. So overall, the Green Ward projects across all 6 saved about just over 420 tonnes. And just over £12,000. So it achieved the objectives that we wanted to, and it also scaled across the integrated care system. It meant that people started to work together more in a more pragmatic way, and also the project was featured in the e-learning for health module that I think was referred to earlier on as one of the areas that in a wider sense across the NHS that people could take up. So we had taken a step towards meeting what our wider goals were. Through that process, through the judging and awards, we'd engaged the executive team, we'd got much more of an engagement across clinical teams, and the projects were delivering sustainable healthcare, reduced carbon emissions, reduced cost, and improving the staff and patient experience. The staff and patient experience on that particular project it was really interesting. The patients valued understanding what their carbon impact was and changing their behaviour. So a bit similar to the point that was made earlier, just by letting people know something they didn't know before was felt to be valuable. So after our Green Wards judging, it happened to be the next day was when the Net Zero report was published. That's been covered already, so I'm not going to go into the details of that. But the timing was very good, and we just then springboarded straight on to developing our green plan. And I highlight this just to give an idea of, within trusts, of the scope of what might fall under a green plan. And that scope is getting larger as time goes on, as we realise more and more what our impact was. But at Frimley, our goal was to try and make net zero everyone's business, and that's going to be an ongoing challenge. Each green plan is generally written for 3 years, and we broke it up into what our direct intervention areas were, so things like estates and facilities, energy efficiency, for example. Travel and transport would involve active travel and decarbonising where we can our fleet. On materials and supply chain, it's looking at social value, as mentioned earlier, how we put that into the procurement process in a fair way, in a consistent manner, and also circular economy where it can be implemented. Food and nutrition is quite a large area that isn't talked about a great deal. So if patients are eating better diets and staff are eating better diets, then the ongoing prevention of healthcare is the outcome that we're going to be seeing from that. And then a large area is medicines, and particularly medical gases, which there are a lot of anaesthetists within trusts who are very active in sustainability. So that seemed like a very good area for us to start to focus on. And we mustn't forget about adapting our systems to the change in the climate that's coming. And then the things that can enable that change were things like the sustainable quality improvement projects, like the Green Ward competition that I spoke about, innovation, workforce and training, and digital. So I'm not going to step on this in a great deal of detail, but what we were able to do was to plot a trajectory on our carbon emissions down to 2039 on our direct emissions, so the direct NHS footprint, rather than the whole supply chain, of what would look like if we could just present to the board, well, if we do nothing, this is inadequate because we're not going to go on the trajectory that's been developed for net zero, and to show what the trajectory that we needed to go on. So we then put together a costed plan to show how much it would cost us to get to net zero with the interventions that we knew we could take. And we had emissions work streams, we had enabling sort of cross-cutting work streams that would help us to get there, and then what I termed allied work streams, which is the things that are going to improve population health generally, but you probably can't account for them in a particular NHS trust. And I think probably the most important step was that we had an executive lead for each of those work streams. And it meant that it wasn't just the senior responsible officer for sustainability who was responsible for the whole programme, potentially alongside someone like myself, and that's it. It meant that the exec lead for people would be in charge of workforce, for example. The exec lead for operations was in charge of adaptation, and so on and so forth. After the Frimley Green Plan, we then expanded to the Frimley Health and Care Integrated Care System Green Plan, which is a similar sort of footprint. And the only point I wanted to make here is that we had our different themes were running across the middle, so that the different themes of delivering a green plan, things like electric vehicles or energy efficiency or food and nutrition. And it was really important, and I think in sustainability we've often missed this as a trick, to link how by implementing sustainability we're going to be reflecting what the organisation is trying to do as a whole. So coming back to what Graham was saying, how does sustainability help to improve patient outcomes? How does it help to tick the boxes that the government's asking the integrated care system to do? Those at the top are the four core goals of integrated care system, and that just happens to be the strategic ambitions of the trust and the integrated care system at the bottom. So just a quick selection of steps that have been taken or going forward. So top left is the new hospital, which has been built at Ascot to replace an old hospital, Heatherwood Hospital, which was actually where they filmed Carry On Matron. So it's a particularly old site. This footprint is probably about less than 25% of the footprint of the original cottage hospital. And it's got enough solar power. The solar power plus the heat pumps and the construction make about sort of 13 or 14% is the planned renewables that will be delivering into that hospital, which doesn't sound like a huge amount, but when you think of the power of a hospital, it's at least a reasonable chunk. And in the centre, at the top there, what I wanted to mention is that we at Frimley started to look at the possibility of using our digital systems to deliver the advice required to clinicians to take more sustainable actions. So, for example, you can use digital to help somebody to make a different prescription choice, or you can give them advice if they've done a particular clinical procedure talking about waste, how you can then put your waste in the correct segment it into the correct receptacle. So those sorts of things are being delivered digitally. And also, there's a walking aid reuse scheme. And another way digital is going to help with that is we're hoping that the digital system will print a barcode that goes onto the walking aid, and then you'll see where that walking aid's come from. So when it goes back into a recycling receptacle, perhaps at another trust, we can see where it's come from. So this sort of innovation is key to be able to push things forward. We've also, I can't play it unfortunately, but we've made an animation that's going to make it hopefully really easy for any member of staff to see why is this an issue, what sort of things are we having as an impact, and what are we doing about it. And then lastly, just at the bottom left, was similar to what James mentioned, is that in the maternity unit, we've now got nitrous oxide mobile destruction units, which makes those areas much safer for the maternity teams, because a lot of the nitrous oxide is being taken out of the atmosphere. I can't see actually. How am I doing on time? Okay, 10 minutes, perfect. Okay, so I wanted to just run through some of the things we're doing at Frimley, just to show that there's, I guess there's different ways of coming at this in order to try and engage as many staff as possible. But then, firstly, I should declare I'm no way an expert in decontamination. It's been really interesting to see the debate this morning. So if what I'm about to say is controversial anyway, then I make no apology. No, it's I'm actually coming into this, I sort of turn the question round. Is decontamination sustainable? So I think a lot of the debate, the suggestions, the way that we do things is about how you can make the processes within decontamination more sustainable. Which areas can you reuse? Which are the areas where single use is going to make more sense? What do you do about your water consumption? Those are areas that all of you guys are experts in and can have a very good debate about. And we'll get to the answer potentially per procedure, per unit. But then I think there are challenges in getting there that are it's worth defining, because those will be, I think, work streams. Listen to everything this morning, that there are some key work streams that are probably useful to move forward to get to some of these answers. And then there'll be some opportunities from working on a system-wide basis. I don't know if any of you seen a video that has been posted. I happened to see it on LinkedIn, but this is a picture of a lady called Maria Koitchik, who wanted to understand what was involved in terms of waste, in terms of the surgical procedure from a breast reconstruction procedure that she had. So she asked the clinicians to keep all of the waste, and it's not verified. This is her posting it, but we have to take it on face value. So you can look this up on YouTube if you wish, and it's just a 1 minute area. She's an artist, but it just brings it home that the amount of waste, the number of items, the variety of items that you use just on one particular type of procedure, we are not working in a sustainable way. We're making small inroads, but I see decontamination and the skills that all of you have as being key, particularly to the reuse angle of how we can start to reuse some of these items. And the central NHS procurement and Greener NHS team have, in the NHS Net Zero report, this is from the report, have put together their view of the trajectory of different interventions that are going to get the system to net zero. Now, I think this is well worth a debate, because they put the main focus as being non-pharmaceutical and pharmaceutical suppliers changing their processes, possibly as they are. And there's very little up at the top about metal instrument reprocessing, device reuse and refurbishment. Now, coming into this, I had assumed that we could make much bigger inroads in those two particular areas by working together with the NHS and suppliers. But it is obviously more complicated than just saying reuse is it. However, I think if we start with the principle that we should be aiming for reuse or avoidance of needing to use the item in the first place by avoiding wasted, patients not arriving for their procedure, etc., is that we do need to do more to really dive in and understand what is needed to reuse more, what is needed to recycle more. And so that was a question I was asking myself from my experience. And there are so many elements to it that it strikes me that there just need to be a few more standardisations that springs to mind. But what is evident is there are arguments on both sides. And just doing a little bit of research for a plastics, I did a paper on plastics a while ago, is that you can find lots of very papers that are in well-respected journals that will talk about, and this is absolutely true, that there are endocrine disrupting chemicals in medical plastics, and there will be certain cohorts of patients who might be more vulnerable to those plastics being used. And the same is the case of, particularly in pharmaceuticals, the mix of polymers that you find in packaging. If it's actually quoted, often there'll be at least 15 polymer types used where they're labelled. Now, having worked in a trust, if you try and work out where you should be segregating that waste and work with your waste contractor to understand how they're going to then process that waste, it's incredibly complex. So I think that's part of the reason why we're seeing a real resurgence or innovation in reuse. So for example, companies like Vanguard, like Ellis and like Revolution Zero, who are focused on how we can reuse more, are increasing the number of items where reuse is becoming a norm for them. And what's interesting is they're either working with particular trusts to work in their premises, or they've got a model where items are going miles away because it makes more sense from an efficiency point of view. And the outcomes they're delivering, and this is mainly evidence from them, but also pilots that are happening, is they are reducing carbon, and there are cost reductions. And there's also critically reduced supply chain risk if you're keeping your materials closer to you geographically. So originally, I think I was thinking coming into this today that I was going to be much more perhaps bullish about reuse, and I think it's obviously still at the top of the hierarchy. But perhaps the way to think about it is that there is a lot of movement and there's a lot more momentum behind reuse, I suppose, is the point that I wanted to make. And just a closing, a bit of a slide as to the way that I see the challenges and opportunities. So if we are going to be doing a lot more decontamination, sterilisation and reuse, then a challenge we've got is that the majority of the heat required for that process is gas derived, either on trust properties or elsewhere. We may have an opportunity to solve that with local renewables, so the sort of projects that James was talking about earlier in Newcastle. And then a big challenge is consistency and standardisation. And as a newcomer to this particular area, I think that's been reflected in the conversations this morning. And I guess the opportunity with that is an improved regulatory framework, proper competency for the members of staff who are working on a particular area, and the training to go with it. And then the buy-in of teams has to be there. So if we're going to move on to a different model, whether it's reuse or a different type of waste contractor or a particular provider, supplier of a material who's going to recycle it, the teams have got to buy into it, procurement's got to buy into it. The FM teams on the ground have got to buy into it, and the clinicians have, etc. So we need to do more work on evidencing all the benefits to those particular teams in trusts to make sure their buy-in is there early, and then you've got much more chance of success. If there's something that isn't there, missing in the buy-in stage, even if it goes through, you'll have problems when it comes into operation. And then the last one is logistics. Moving on to reuse and recycling in some circumstances, there needs to be a change in logistics. And I think the opportunity there, and it's probably an easier opportunity than the heat one, is that transport is decarbonising in a much more natural way than heat is. So just in conclusion, my thoughts were the key element, which all of you guys are involved in today, is collaborating across services, so from sterile services to the particular clinical services involved, between the public sector, between the NHS and the private sector is key, across the integrated care system and the region, but also sharing best practice at scale, and that can include potentially sharing infrastructure, which was my suggestion to leave my talk in. Thank you.